I want to thank our SSF staff. We had a phenomenal residents and fellows course. We had a sellout with 50 residents from around the country, and neurosurgery and ortho. Phenomenal faculty throughout. You can all log in and watch it for free. It was a magical thing to be together, but also want to thank the over 1,000 people who participated online. So this is really very cool. The most amazing thing was the sparkle in the eyes of our participants who just really loved the direct interaction and cadaver courses. We're literally full until the very end on Saturday evening, but this would have not been possible without industry support. This would have not been possible without the amazing work of our SSF staff. As always, we have a couple of cases coming, but I want to specifically introduce and thank, and Ben, can you go on robot camera? Our colleagues from the South Sound area. We have a phenomenal group of colleagues here, and we'll have an eager participation. Bob, can you hand the microphone around to all of them? I'll just pass the microphone, maybe next to you is Dr. Covey, and they'll just quickly say hi, and the robot camera will, this is not Dr. Covey. Dr. Covey is next to you, but that's okay. We'll start with that row. Here on camera, you're live.
Oh, thank you. Thanks for the introduction.
This is Dr. Yos Covey, and who's next to you?
Sarah Dean, PA with Dr. Covey.
Good, and right behind you then?
Dan King from Madigan Army Medical Center.
John Blair from Puget Sound Orthopedics.
Mike Martin, also from Puget Sound Orthopedics in Tacoma.
And then behind you, we have somebody from out of town with a very cool blue and white tie.
Dr. Foda Suslian, Denver, Presbyterian St. Luke's Hospital, previous fellow from Swedish 2013.
Great, awesome. We don't have to go throughout the whole room unless somebody else wants to introduce themselves. But we thank Therapeutics for their guest speaker today, Dr. Jeffrey Marx. He's a PhD, and he's going to talk about something that all of us are still really needing very much, and that's a question of how to achieve effective and safe fusions in the most cost-effective manner. And just a disclaimer, we're not here to promote any specific product. We're not here to promote fusions per se, but fusions are a necessary and highly important factor in our world and our work. And as always, we'll start off with some cases, and we have a phenomenal group of fellows here. Dr. Sassino is going to go first. She's an MD, PhD, and we've selected a couple of cases to stimulate some debate. Dr. Martin, you have some cases also?
I do, but unfortunately we have some technical difficulties, so we'll have to wait until next month.
Next month, okay, but you're on next month. Dr. Sassino.
Good morning. As Dr. Chapman said, my name is Amanda Sassino. I'm one of the Complex Spine Fellows. I did my neurosurgical training at Johns Hopkins Hospital in Baltimore. So today I'm going to present a case looking at deformity. You know, when we do these large cases, you know, initially post-op, we're looking at the CT scan and we're looking at our hardware placement, and we want to see how our patients did. But longer term, we're really looking to see, you know, the patient developing adjacent segment disease, you know, how is our construct holding up? Did the patient fuse? You know, and overall, just how is the patient doing? Did that really matter? So for this case, it's a 63-year-old female who had a history of juvenile idiopathic scoliosis. She had come into clinic with lower back pain and left lower extremity radiculopathy, and basically had failed conservative management. And on exam, she did have weakness in her lower extremities. She had decreased sensation, and she also did have some hyporeflexivity. So initially here, you know, she had gotten all the pre-op workup. She had gotten a CT myelogram, MRI, but I really just wanted to show the scoli film, since that's the main thing that we're going to look at here. So for the operative intervention, she had a T9 to pelvis with a quad rod construct, and she had multiple levels of osteotomy for correction. And then post-operatively, she had a good correction. She did very well in the hospital. And then I'm just showing a comparison from her pre-op to her initial scoli x-ray that was done post-operatively. She did have one initial post-op CT that showed good placement of all the hardware. And then finally, just following her out about a year after the surgery, she just kind of gotten routine scoli x-rays. And this is kind of to the point that I wanted to make, is that with these types of x-rays, it's really difficult to tell whether the patient fused or not. Obviously she maintained good alignment, but it's.
This is great. You don't have any neuroimaging, right?
No.
So there's moderately severe to severe foraminal stenosis, nothing prohibitive. You saw the neuro exam that was foraminal stenosis. It was pretty bad. And I just wanted to quickly maybe we'll start with Dr. Kang. How long, when we have a degenerative scoli patient, we have to talk into the microphones, do you get to know a patient before you kind of start considering surgery? And what are some of the eminent prehab things you'd like to see in an adult deformity patient?
Thanks, Jens. Yeah, that's a great question. I think we obviously want to optimize the patient as best as possible, but they usually come in at, in their 5th and 6th decade with multiple medical problems. I think from a spine standpoint, we want to look at their bone health, I think is the first thing. When it comes to medical optimization, I think we have to look at their other comorbidities, whether they can handle a larger surgery. So I think they have some timed up and go tests, things like that based on their stenosis. But it looks like from her, this primarily pain from her scoliosis in her back pain rather than and radiculopathy from her foraminal stenosis rather than a central stenosis. But I think, I do usually have them come back. I know obviously we have our Virginia Mason folks who have a pathway. I don't have a multidisciplinary team like that, but looking at them from a behavioral health standpoint, Kim and our colleagues trying to optimize non-surgical treatments, and then getting them through some prehab with PT to see how they're gonna, be able to handle the post-op recovery.
Maybe you want to pass the microphone on to John or Mike. We can't speak to everybody, but this is a pretty extreme thing. I'll take ownership of this, but nowadays, do you try to do less invasive surgeries like with far lateral procedures or less invasive anterolateral procedures to get anterocom support? Here, I like these posterior procedures, but there's a lot of metal in that patient also. So what's your approach towards this surgically? Do you do more less invasive or more invasive things?
Yeah, I tend to approach these things a little differently. I do something less big, treat the levels that are stenotic. If there's some instability, fuse it. If there's not instability, sometimes I'll just do the laminectomy and decompress them. And I think that that's a reasonable alternative for folks who have significant radicular component without a lot of back pain. If they have a lot of back pain, then I'd more consider something bigger.
So let's go to the gentleman in the black shirt, Dr. Hart. So he is one of the senior members of the ISSG, the leading deformity group in the world. So I put a lot of hardware into this patient, as I said. I don't think we used bone morphogenic protein. We just used a mix of local bone graft and allograft, I think. So I think a 50-50 ratio. And how did the patient do, actually, Amanda?
She did. That's my last slide. She's doing very well, actually, considering.
So all things considered, I think we usually have outcome scores, but that's okay. The outcome scores were well. She was off opiates, but this is, overall, she did quite well. She's not perfect. But if you go back to alignments, so alignment goals is one of those things that ISSG has promoted greatly. I'm worried that it kind of serves as an indication for surgery. This is not the worst curve in the world. She compensated a little bit. Critique me, just hit at it.
Yeah, the phrase I like for a curve like this is the tyranny of small curves, right? So this is not a deformity that is causing this woman any difficulty in and of itself. So her alignment is neutral in both planes. She's got some thoracolumbar kyphosis or upper lumbar kyphosis. That's maybe the most worrisome of any of it. But, to try to do this without fusion, which I think undoubtedly some surgeons would, and I'm not saying that's a wrong approach, but I think there's enough evidence of instability, particularly on the coronal view, that may not be enough to manage her neurogenic claudication long-term. So I'm worried that she would slide off. So then your options are, if you're going to do a fusion, how long? And I appreciate the idea of doing a shorter segment fusion. I think that, might be at least a short-term and short-term, mid-term, intermediate-term solution for this woman. It might last 5, maybe 10 years, maybe longer. It's hard to know. These are patients that we really don't have good data on, but if you're going to do a fusion of the length that you did, then I think you accomplished the goals of that operation, which are, adequate decompression, adequate alignment. In fact, almost, I think, perfect alignment for her in both sagittal and coronal planes. And you want to do everything you need to do to get fusion. I would have definitely used BMP. I'm definitely a user of BMP in off-label uses, which this would be considered off-label. But that is one thing that we did have data on out of the ISSG, that patients who had BMP for long fusions have a higher fusion rate. So other than that, I have no critique.
Quadruple rods, triple rods, this has become more and more common. Are we just kicking the can down the road? Are we going to have them all break apart 2 years from now rather than a year later?
I mean, we just don't know. So non-union and rod fractures can happen out to beyond 5 years in these patients. I've gone to 4 rod constructs for something like this. There are a number of different patterns, and you've kind of led the way in kind of cataloging those or categorizing those. So I definitely would use 4 rods. I think again, I've said at other places, we're beginning to see new alloys that may change how we approach this from a surgical standpoint. It may reduce the number of rods we need, but for now, with titanium, I would use 4 rods.
All right, and Rod, as one of the founding three, but I want to make a comment about the multi-rods quickly. Thank you, Bob. Far lateral surgery. 2 of our fellows, Dr. Cook, who's here in the audience, and Dr. Tataran, who's still recovering from hot yoga, I think. No, he's here. He's not. He is here, snuck in the last row, invisible to me. The invisible Dr. Tataran. They're both putting out very cool papers on multi-rods to kind of get it more systematic. I want to thank them for their efforts. Rod, what are your thoughts on far lateral? When I came here, you did a lot of far laterals for these deformities. Is that kind of passé? Is it too invasive? Does it hit the plexus too much? What's going on with that now?
I mean, I think on this case, looks like 4 or 5 would be difficult to get. But yeah, you could do 2 or 3 levels laterally. I think that's reasonable.
You still do that?
Yeah.
Higher, easier, lower, easier, concave, convex side, right, left?
On this one, I think the apex is a little higher than normal. Usually it's at 3-4 here. It looks like it's at 2-3-1-2.
So we start with Dr. Cecino. She's from one of the great programs in our country where robots are in common use, Johns Hopkins. What would have been the Johns Hopkins approach? What would you have seen with your faculty there?
So with our main deformity surgeon, he's posterior approach. So he would have approached us in a very similar manner as you did.
Oh, wow.
Done many cases with him like this.
And robot?
Yes, we do use the robot for these cases.
How does the robot compare to the Yenzobot? Honest answer. Okay, if you choose to not answer, that's okay.
I will say that when you have complex deformities and the anatomy can be very challenging, it is nice to have the backup of navigation to help plan with the screws.
Yeah, no doubt, if you have a fusion, especially an old fusion.
Yeah.
Thank you, Amanda.
Thank you.
So we'll next go to a co-fellow on the service. That's Dr. Chris Seidel. Let me do my, yeah. And so this was a relative success story, a big surgery, no doubt, and analogous, but with a twist now, to raise the question of fusion. Chris Seidel, and just tell us where you come from and.
Yeah, so I'm Chris Seidel. I trained in orthopedics in York, Pennsylvania. All right, so this is a very complicated patient with extensive backstory and surgical history. And so this presentation is really meant to focus mostly on the recent encounter, but for context purposes, I'm gonna give a very condensed version of his timeline. So a 76-year-old male farmer who first presented back in 2019 with kyphoid scoliosis for which he underwent a corrective surgery at that time. I'm gonna show images, but I'm just gonna kind of give a quick rundown. He did well for a while, but then he suffered a fall off his tractor in 2020, resulting in a T3, T4 flexion distraction injury with a loss of fixation at the top of his construct. He underwent revision surgery, which I'll show later. And again, he did well for a little period before he sustained some sacral insufficiency fractures and followed up with main complaint being pain and a bursa he felt in his low back. His past medical history is significant for osteoporosis, hyperparathyroidism. On his most recent follow-up, this is what his physical exam was like. He had a lot of pain with prolonged sitting and with activity. He had this fluid-filled bursa in his lower lumbar spine, basically neurologically intact. So these are some representative images from prior to his first surgery with us in 2019, showing his kyphoscoliosis, multi-level degenerative changes. He's got areas of compression throughout his lumbar spine, even up into the thoracic spine. And you can also see that there's a prior T8 compression fracture. So in 2019, he underwent a decompressive laminotomy for correction of central foraminal and lateral recess stenosis, T11 to S1. He had 3 column osteotomies, T12L1, 1-2, 4-5, and 5-1. Placement of inner bodies at 5-1, 4-5, 12-1, and 1-2, and instrumentation all the way from T4 to the pelvis with quad rods and bone grafting. I don't think BMP was used at this initial surgery.
Just a signature. This is, by the way, so this is all a setup, obviously, and Dr. Oskouian just had to leave the room, but you can see this collaboration, Dr. Oskouian's signature of, I think, 3 or 4 level of far lateral cages, and my cages on the bottom. But yeah, keep an eye on that. But this is an example of how Dr. Oskouian and I frequently work together, and he's just a master of these far lateral procedures.
So the following year, 2020, he had the unfortunate fall off his tractor, sustained this high thoracic injury just above his prior construct. He presented with progressive weakness and underwent a surgery where the implants around that level were removed. He underwent decompression from 2 to 5, costotransversectomy at T4 to allow for correction of the kyphotic deformity with an expandable cage. And he was instrumented from C2 down to tie into his previous construct. And so here are some representative images you can see on the CT where he's got that flexion distraction injury, and then his correction in the 2 scoli films right next to it.
Dr. Oskouian just joined us again. So this is one of those collaboration cases where you did the far laterals, and then this man came in the middle of the night. He had fallen off. He was seen outside hospital, left there with an incomplete cord, Asia C, for a number of days, maybe even a week almost, and he was in a pretty bad situation. And Rod actually was so kind to come in at night, and we did this together. So now here we have this bad situation of a C2 to pelvis fusion. We could stop there, but I want to ask maybe Dr. Covey, as our Canadian surgeon of origin. This man could be a Canadian. He's super nice. He's incredibly indolent.
I'm actually from the Netherlands, but it's very close to Canada.
Same thing. Covey is I thought you had kind of done Holland, Canada, Seattle, but I'm obviously wrong. I apologize if that's an insult. I hope not. I love our Canadian colleagues. So the man is very indolent. He could be Dutch. And he has a farm. And here, yours truly had given him a T4 to pelvis fusion, thinking that I had made him bulletproof. I allow my patients to usually go back to activities. This man has a large property, and he likes to farm it himself, and he has a giant array of tractors. They usually have a green color outside. I'm not going to make a product description here because we're on the CME segment. But this is one of those industrial tractors that he fell off of. Am I just dumb to let my T4 to pelvis fusions go back to everything? Would you restrict patients? How do you handle these people who like to do everything and have a big fusion?
Well, if this is, of course, one of those things you would blame it, oh, this was maybe high energy, but it could have maybe happened with a minor fall at his home also. This is just a huge stress riser. He's osteoporotic, he's 76, so the risk is there. Probably it wasn't necessarily in high-speed tractor race where he fell off. It might have been, but it probably more the stress rider from the extensive surgery, I would think.
So the point is, do we put these long fusions into a protective bubble for the rest of their life? Do we put them into a post-tab programmed to try to avoid this?
Well, that's probably not realistic. If you gave him that option, he may have decided, I don't want that surgery in the first place. That's what I would guess. But no, I don't think that's a good option. Then
So I forbade him the tractor, the big tractor now, but the smaller ones he still rides, because now the odontoid is the next thing. I can't have him fall on his head. Dr. Kang, I remember a great lecture of yours, proximal junctional failure, PJK, PJF. Do you do banding? What do you do in these longer cases to try to minimize the occurrence of that outside of trying to rebalance the spine and all that?
Yeah, so I think the big thing is obviously decreasing stress at that proximal construct. I think laying the rod in, so when you put it in, you're not having anything pull back. So getting those sagittal benders and bending them in. The other thing I've been doing is I haven't been doing adjuncts like bands or or vertebroplasties like some places like Hopkins kind of initially described. I think the other thing is not putting the screw in so it hits the cortex. I think that's been described where you leave a couple threads out. They call it hubbing of the screw, because I think that causes some fractures you can't see. I mean, obviously exposure at the top, you're barely seeing the top of the TPs, not trying to get into the facet joint. And I think leaving the screw a little bit proud at the top. But I haven't been doing, I know your other construct had some hooks at the top for soft landing. But those are the things. The other thing that I think Larry described is the Hamza techniques, kind of hybrid open, muscle sparing. I haven't been doing that because I think it's hard to like actually get, there's a lot of blood there. And then ultimately when you lay a rod in, there's just crushed muscle in there. So, but you try to obviously save as much of that supraspinous ligament and the soft tissue around there as possible.
Great. And I think those are really, in a brief sequence of sentences, very valuable points. Now we're not at the twist.
Yep.
The twist comes.
Fast forward to this year, he rehabbed okay after that surgery. He had a little bit of weakness that he got better through physical therapy, but still had this lower lumbar pain with sitting and activity, and that bursa that developed that we evaluated when he came as follow-up. So here you can see his imaging. He ended up with this pseudoarthrosis down here at 5'1". You can kind of see on the sagittal CTs. He has haloing around his S1 screws bilaterally, as well as the iliac bolts. And it's difficult to appreciate in the x-ray in the center, but he's actually popped out of the tulips of the iliac bolts there distally, and the caps are floating.
So this patient actually developed a sacral U fracture. Self-advertisement, next Tuesday, tune in Pacific time, 5 p.m. We're going to talk about sacral fractures in the Interesting Case Conference, and we'll review all sorts of sacral fractures in a 1-hour format, so please tune in. But yeah, this patient had a sacral fracture in the presence of a non-union, and I take full ownership of that suboptimal left iliacus screw, not iliac screw, but iliacus screw. That's not a perfect placement, to be kind.
So he's now status post-revision, where we performed selective hardware removal from T12 to the pelvis, debridement of that non-union site. We did a formal bilateral SI joint prep with fusion with structural fibular allograft, BMP. He got a quad rod construct. We just revised distally, new iliac screw fixation, obviously. And he did well post-operatively and was discharged within just a couple of days back to home. So I think this case raises a couple questions. I mean, 3 years had passed from his original lumbosacral and pelvis fixation. And on follow-up imaging, it appeared to be healing, but clearly had a failure due to incomplete healing, and there was haloing and pseudoarthrosis. So at what point do you say something is really healed or not? And on that note, an argument can maybe be made that given his osteoporosis, because he had DEXA scans going back to 2020 and even before showing osteoporosis, at what point do you think maybe an anterior procedure for a larger fusion footprint should be considered? And lastly, again, with the DEXA, what preoperative intervention should be considered regarding bone health in patients that are going to be undergoing long constructs, which we kind of already alluded to earlier, and whose role is it to take care of that? Is it us? Should it be the GPs, or who should be taking care of bone health prior?
So if you go back again to the initial failure thing, so I own the left iliac screw. This was regrettable, but maybe John Blair can talk about this. So haloing around the iliac fixation. We've come a long way since our era of Galveston rods, which very commonly had this windshield wiper effect. Should we pay attention to the haloing? Does it matter when the iliac fixation fails or not? It's a supplement, right?
Yeah, I certainly, if you use the hailing, that's an indication that bad things are coming your way if you choose to ignore it. So early revision is certainly appropriate, but optimizing bone health is critical as well. This patient, whether or not you go anteriorly and put in a cage at L5S1 prior to this complication happening is dependent upon the patient's anatomy down at the L5S1 level and how much you have faith in your approach surgeon as well.
At this point in time, this would be pretty hard to get that steep of an angle. I mean, this patient has a very ugly entry angle.
Yeah.
So would you have gone anteriorly in the salvage procedure, or is the quad rod with quality
I think
pelvic
going
screws okay?
posteriorly with that fibular strut is an excellent option.
Okay. I just want to point out on the sagittal CT, the differences of bone healing. The two upper plastic peak cages have healed quite nicely. Rod, are those X-lifts healed or not?
I got it. It's hard to tell on the coronal, maybe we can see, but looks like there's bone growing around the cage, not through the cage, which is very common.
Now, if you go down that L4-5 titanium cage that I put in, is that healed or not?
It looks like it is. Looks like there's bone growing through it, actually.
So and then if you look at the axial top right, the same can't be said there, although there's bone in the cage, but then there's radiolucency around it.
When did he develop the sacral U fracture? Is it hard to tell?
Yeah, I don't think we have an exact date for when because it was insufficiency. There wasn't like an actual injury involved with it. It was just, he came with increased pain. We saw that he had this age indeterminate kind of sacral fracture. It was already healing. And it went on to heal on its own.
So in your residence in Pennsylvania, did the deformity surgeons do a lot of A-lifts to kind of get better fusion mass rather than these two titanium cages and bone graft?
So interestingly, and I hope this doesn't create any controversy, but my orthopedic spine attendings were very big proponents of A-lift, but my neurosurgery attendings did not like the A-lift. So it was kind of, depends on whose patient this is.
Great. Okay, let's go to Dr. Schlaudraff, and he has a case that was done differently, and that's just recently popped up in our clinic, so we can see that, and I'll want to particularly harp on Dr. Hart's comment here, and anybody who wants to talk from our faculty, obviously, but Abe, can you introduce yourself?
Hi there, Abe Schlaudraff from Penn State.
It's a Pennsylvania connection. Are you invisible? Do you need help from Ben?
No, I think these are my slides. They're just,
So whilst we're waiting and giving,
I have to grab my,
we'll wait for Abe to kind of get organized. Dr. Hart, tell us your thoughts about, so you've started doing something a couple of years ago to try to get better interbody grafts. So what is your current thinking? Because that'll actually, it's okay, we can talk about that before we have the slides. What are your current thoughts on deformities and multi-level fusions?
So, I do a combination of TLIF and either oblique or straight anterior grafting. I really do like anterior grafting for 4-5 and 5-1 in particular. I just think I get a better access, I get a better fill. Maybe that translates into a better fusion rate. I've talked here about the order of events. I prefer to do the big posterior operation, do as much from the back as we can do safely and in a reasonable amount of time and blood loss, and then if needed, come back and put grafts in on a delayed basis 4 to 6 weeks post-op from the big operation. And by that time, patients are nutritionally replete, their pain levels are better, the amount of time that they spend in the hospital for that second stage is relatively limited, and I've been happy with that approach. As opposed to trying to do both stages in one hospitalization and not that far apart, which I think may lead to a situation where the patient at the time of their big second stage posterior operation is suboptimal physiologically.
Dr. Martin, so he does his A-lifts after the posterior procedure. Can you share the microphone with Dr. Blair? Conventionalists usually do A-lifts first and then do the posterior procedure. So what do you do?
Currently not doing a lot of A-lifts. We have a paucity of good approach surgeons. So I've been doing all mine posteriorly, but when I was doing them anteriorly, yeah, we went from the front first and then did the posterior. But you know, with big multi-level surgeries like that, it's interesting to hear, Bob, that you're doing it the other way. Do you have any difficulty getting reduction if you have to reduce or realign things after they're instrumented from behind?
You have to show them.
So I think with posterior osteotomy techniques, you really can get the alignment posteriorly. So at that point, the second stage is really just about fusion. It's not about alignment. And I did want to say one word of caution. You referred to those osteotomies as 3-column osteotomies. And I think when we do the intradiscal osteotomy that Dr. Chapman has developed, really truly is a 3-column osteotomy. It's not on the Frank Schwab SRS classification of osteotomies, actually. It is 3-column in my opinion because you take both facets off and then do a big discectomy and interbody fusion there. It's obviously different than the traditional thinking of what a 3-column osteotomy is, which is a pedicle subtraction osteotomy. And the discs that have been done from the side and then from the back, I think most surgeons would say that doesn't quite qualify as a 3-column osteotomy because at the posterior operation, you're just doing facetectomies. So I think most surgeons would call that a posterior column osteotomy.
All right, Abe is ready. Let's see how this illustrative case may hopefully enlighten us. You have to speak closer to the microphone.
Abe Schlarner from Penn State, going to talk about primarily A-lifts and what type of grafts and biologics are used in them for pseudoarthrosis prevention. So I have an individual, very pleasant individual in his 60s, male, very, very active, hikes miles up in the Olympics and in the Cascades. 2014 originally presented with bilateral extremity radiculopathy and neurogenic claudication, which was limiting how active he could be, how much he could hike. And at that point, he underwent anterior reconstruction first with L3 to S1 A-lifts using allograft, structural allograft interbodies, then had a T10 to pelvis posteriorly. After that, he did very well until about a year or so ago, until last Christmas. He was able to hike 8-10 miles a day without any issues, very active. But then Christmas developed bilateral extremity L5 radiculopathies, increased low back pain. He originally tried conservative measures, then presented to our interventional spine clinic, then to our clinic as well. You can see on exam there, he has mostly full strength, except down bilateral distal lower extremities, has some weakness with his extensor hallucis. Otherwise, his reflex are normal, sensation normal, nothing pertinent in lab imaging. Here's his preoperative imaging for his 2014 surgery. You can see there, I just have one sagittal MRI, but also he had pretty severe foraminal stenosis bilaterally, kind of extensively throughout the lumbar spine. He had that relatively balanced scoliosis imaging. He does have a coronal deformity there and a loss of lordosis. So he ended up having this procedure here. You can see those allograft A-lift cages at 3, 4, 4, 5, 5, 1. And overall, pretty well balanced. More recently, you can see here, primarily focusing at L5, S1, where we had a osteoarthrosis. You can see some hailing around those S1 screws. You can also see on the right image and on the second from right image that the end of the construct has popped out of the iliac tulip heads. You can also see black disc there at 5-1 showing pseudoarthrosis as well. And posteriorly, in the posterior elements, there is no fusion across the 5-1 disc space. And this is his most recent scoliosis X-ray.
So, Fotis, can we, okay, yeah, thanks. You've been quiet how long I've spared you. You've been quiet here. This is a surgery done by one of your former attendings. I'm not going to mention his name, but he's retired now. I'm not doing this case presentation because he is gone, but this was a surgeon who you worked with a lot, and he did very, very diligent, did I say diligent? Very lengthy, diligent procedures, as you'll fondly remember. And he put in giant, was this a peak spacer? I think it was a peak spacer filled with bone graft, right?
I think you said.
It was an allograft or peak.
I think it might.
I don't remember now, but I think it was maybe an allograft ring. But so.
He used to fill with iliac crest harvest sometimes.
Okay.
You know, I wasn't here for 2000.
Can you go closer to the microphone? Yeah, these are.
He used to fill with iliac crest harvest. You know.
So you're a very successful practitioner in Denver. You've combined minimally invasive with large procedures. This is a procedure done by this colleague. This patient did very well, super active, very positive person, no risk factors for non-union. And here, years later, he comes back, he now has severe L5 symptoms, and we will have to revise him. We have now no post-ops to show, but this very solid anterior colic. Did I say diligently dissected? I did not mention that enough. I can't say it enough. A 3 or 4 level anterior fusion has evidently now broken down. So what are your thoughts? What do you do to prevent that? What have you done in your own practice?
Yeah, this is obviously a very nice case, but you know, you could always, hindsight is 20/20. Looking at this construct, you could always go a little bit longer in the iliac fixation. When you do this, you kind of set yourself up a little bit for failure, especially in a very active patient. Now we know that we have to also potentially think about the concepts of what do I put for my patient, right? What do I need? And the two most common variables for implantation are what? Bone quality. This guy has good, this patient has good bone quality, and expected demands of the construct. I worry that the distal end of the construct may have been a little bit pusillanimous in this patient. You know.
So do you do quad rods nowadays? What do you do to try to?
Thanks to what we learned from you guys, yeah. Quad rod, tri-rod, et cetera.
Mm-hmm.
Yeah.
Do you use navigation to optimize iliac screw placement?
Unfortunately, I do.
But you don't have an iliac screw like I showed the iliacus screw that I was not happy about in retrospect, but whatever works. There's nothing wrong with that. Yeah. And in terms of augmenting fusions, I have 2 follow-up questions, and I'll ask the second one probably to Dr. Covey again. What do you do? What do you use nowadays to try to optimize fusion? So what bone graft materials do you use?
So I use a combination of autograft, allograft, and I've kind of steered away from BMP just because of the complications with it. Or risk factors with it. So I use a lot of P-15 peptide.
So let me just harp on that. I have no conflict of interest with the manufacturer of BMP. I can say it very loud and clear. Yeah. There's a lot of talk about complications, and I try to always be fair. Yeah. What are these complications that I hear about BMP?
So I've had a lot of...
I know one complication. It's the gelt. It costs a bit. I don't have a wallet anymore. Correct. But aside from that fiscal complication, what are the actual medical complications?
So one of the worst that I've seen was actually here at Swedish when I was a fellow, and there was significant osteolysis. It was something I'll never forget. And it happened again about 1 year into my practice. Also, I had a patient with radiculitis, and we did kind of the $1 million workup for that patient, and ended up just being BMP radiculitis. So there are issues, but also cost, et cetera, and cost benefit for me and my patients. And a lot of the increasing costs of medicine and administrative push to decrease what we're putting into patients. I think there's an excellent alternative for my practice, and in my practice, I use P-15.
So the question about the radiculitis and osteolytis, is there common denominators, a common pathway that can explain that physiologically?
I think that's a question for our biochemists, et cetera.
So we can bring that up later. Yeah. Any one of our visiting faculty have an explanation for that? I'll postulate it's inflammation. It's a very substantial inflammatory causation. The radiculitis, Dr. Kang, are you conflicted about BMP? Yes, no? Zero conflicts. Okay, let's give him the microphone. He's a government employee, so you have to speak the truth and nothing but the truth.
Yes, yeah.
So G-D help you. So what are your thoughts? Is this a complication-prone device, or is this an effective device as BMP?
I think it's the dosing. I think obviously the release of the BMP from the collagen sponge happens a little bit faster than some of these other potential substitutes. So I think ultimately, the dosing's been the problem. I mean, when you're stuffing a large cage or a large BMP into an A-lift cage or into a T-lift space, I think you're going to experience osteolysis. Or also the timing of it. So sometimes you have to wait that 15 minutes. I know some surgeons get in a hurry and the BMP is not cooked yet, and you just say, let's put it in the cage, put it in the disc space. So I think that's also why some of that leaches out and ends up causing radiculitis. So I think these are factors that I trained at a location where we use a lot of BMP, and I've seen it work well. But yes, certainly there are potential complications, but I think people have overdosed it potentially and cause some of these complications.
This is a huge factor. And if you look at last weekend's presentation by Dr. Jeff Wong, who's arguably one of the leading experts at bone grafts, he identified BMP, if you overdose it in allograft, is causing this osteolysis. So I have honestly I'm not a proponent of it, but I'll use it in healing impaired patients or those who I deem as such. If I keep that BMP away, I have not seen radiculitis. This is clearly a problem if you let that leach out, don't cover it with bone graft. So that's not a factor. And I just want to address oncologic concerns. We published twice, so here I'm conflicted, but we have two very long-term studies that we did with tens of thousands of patients in Washington State. Kudos to Joe DeTore and Joel Weiss from UW, but we found zero oncologic concerns. Jos, I have a different angle question, so Dan, if you can bring that forward. If we see radiolucency in a patient who's otherwise asymptomatic, this patient was asymptomatic for years before this fracture and obvious collapse happened with radiculopathy, should we preemptively operate, and when should we intervene preemptively surgically when you see radiolucency? It's such a common phenomenon on digital x-rays nowadays.
If the patient is asymptomatic, I would probably just follow closely. I don't think I would suggest going in, because it might be years, and the revision process won't be all that much different if you wait for rod fracture.
Okay. Bob, what happened here? I mean, this is a case that you should have been happy about. Technically, a very nice carpentry applied, I think. Why did 5-1 fall apart? We know it's the highest forces, but...
Well, it's multifactorial. I would argue the alignment here is maybe a little suboptimal. This, to me, looks like it's a little underlordosed. I think that sacrum on the right view, if you look at it, is very vertical. You can see there's a little bit of retroversion of the pelvis. And also at the proximal junction, he's kyphosing and degenerating a bit above that. And I suspect that's in part due to the pelvic incidence and lumbar lordosis mismatch as well. And I think that can contribute to non-union in addition to all of the biologic factors we've identified. So, at the time that this was done, I guess it was 5 years ago, or?
Yeah.
2014.
2014. In 2014, I definitely was not using quad rods. I was using BMP at that time as well, but our profession is a humbling profession. I'll say that.
And did you see the complications with radiculitis and osteolysis with BMP? I think Dan Kang made some very good comments. What are your thoughts on that?
So I'm a big proponent of BMP. I do have a conflict with Medtronic, but not one that involves biologics. And my use of BMP predates that conflict. Again, I referenced the work that the ISSG has done, and actually Shea Bess was the lead proponent on those studies. And those are not prospective randomized studies, but they are specific to deformity patients, and they consistently showed that we get a higher fusion rate when we use BMP and a better set of outcomes. I have seen radiculitis, absolutely, and I agree completely. I think it's dose-related. The case that I recall many years ago was in just a 2-level T-lift patient, which sadly was well, in any case would be sad, but in this case was a coworker and a friend of my wife's, which made it even a more difficult sort of personal impact. So I have gone to using only one sponge in a disc space, and I've found that I get very little radiculitis in that setting. I don't use BMP in anterior cervical procedures. That's the one situation where I've steered away from it, and I still don't use it in cancer patients, as we've talked about, even though I'm not sure the data really supports that, but I'm still cautious in that regard.
So Rod, you're the former professor for Dr. Suslian, and what do you do? Dr. Hart uses it more. I use it very selectively. What do you do to enhance effusion?
I mean, I use very little of it, and I think I've had good results with just local bone graft and allograft. So that's my experience.
Mm-hmm. So Abe, coming back to you, and then we'll move on to the final case. What were you taught, and what are we going to do next to this gentleman? He's not had care yet. He's literally from clinic from a very recent past. So what were you taught to do, and what are we going to do for this gentleman?
Yeah, we use very little BMP back at Penn State. Every once in a while, judiciously would use it if we think someone had a high risk of osteoarthrosis, but would not use it in everyone. And a lot of times, a case like this, we would probably definitely use it for a revision. I have a couple points on that. What do you do next? Do you do 2 iliac points of fixation bilaterally? Do you do a quad rad now to revise it? Do you go anteriorly for the malunit or go from behind? I guess it kind of depends what the spacer looks like.
So I myself, we're getting a CT myelogram and we're getting bone density tests of the non-spine area, of course. I'm going to do this from posterior. We should have pulled some cases, but these anterior non-unions, I don't like to go in anteriorly, although you could do a contralateral approach and probably get to that graft and take it apart. But this is a pretty maiming procedure. This patient's been radiated also for his prostate. So this is going to be an ugly retroperitoneum, pre-surgery plus radiation in the lesser pelvis. So I do these posteriorly, and I basically destroy the graft from posterior, and I don't care about that interference screw. I will just leave that, or I'll cut the screw that's in the intervertebral disc space. I'll do my usual construct. You saw it before. I will fuse the SI joints, so we have as good a pelvis to lumbar spine fusion as possible, and I'll probably do one of those turn-down grafts of the iliac crest to L4. So basically osteotomize off the test, just like what we did in the previous patient that we showed. So it's probably going to be the same construct that they'll end up with. The question here will be, what does the thoracic spine look like? What's the junction zone look like? He's pretty imbalanced, and I don't want to overwhelm the patient. So there's a cardiac condition also, as we saw in the wires in the chest. But basically, if I just concentrate on the lumbosacral spine, that's my plan. Any suggestions from the other faculty? No. Okay. So last but not least, we'll have Dr. Jimmy Hicks from Alabama. Thank you, Abe. And Dr. Jimmy Hicks is going to present a case, I think, of Dr. Oskuian's. Is that right?
That's correct.
Yeah. And you're involved in that, right?
Yes. So
as you pull your slides up, can you just introduce yourself quickly?
Yeah. So Jim Hicks from Alabama, Birmingham. Did my training there. Now one of the new spine fellows. So I can go to presentation mode here. Okay, great. So Miss G, she's 68, history diabetes, other comorbidities. She recently had a revision posterior spinal instrumentation fusion from T9 to pelvis for adjacent segment disease and further stenotic symptoms. She had multiple procedures prior to that. And then she starts to complain of more myelopathic symptoms, difficulty ambulating specifically, and progressive deformity and gibbous in her back. So we took her, obviously, for her PJK that she had proximally. Some people could argue PJF.
Can you speak closer to the microphone? You're going to be hard to hear. Sorry about that. Yeah.
So proximal junctional kyphosis and failure at the proximal junction here at T9. So 8-9 being the locale of deformity. So that's what she was taken to the operative theater for. And just in terms of talking about non-union pseudoarthrosis, intraoperatively, we did note by these dominoes around L2, there wasn't much bone mass posterolaterally. And so we could argue that this is some early evidence of an atrophic non-union. And so we did address that with significant bony debridement, stimulating some of the cancellous bone there.
Dr. Hicks, may I interrupt you? Do you know the names of the 3 cages starting from bottom towards L3-4? This is a great history.
So I do not, and it may give a reference to the time frame of her surgeries, but I do not know.
This is an awesome display of everything. So at the very bottom, we see Ray cages, as in Charlie Ray. He broke those out at the same time as the so-called BAK cages came out. And this is a neurosurgical cage. BAK was an orthopedic cage. I loved the Ray cage. An amazing construct. You could not recreate lordosis, but from a healing standpoint, and like for a spondylolisthesis, unparalleled. It's no longer produced. You can buy them online on eBay for like $100 for the whole set. Next up is, what is that, Jimmy? What do you see there?
I really couldn't tell you.
This is a classic allograft, nicely put in the coronal plane. Did you do that, Rod? Looks beautiful.
This is interesting. So Paul Anderson did the first one. David Hanscom did the second one.
And then what do we have above that?
And then that's just a titanium T-lift cage.
That's a Brannigan cage.
Yeah.
Are you sure it's titanium?
Yeah.
Yeah, okay, all right.
Yeah, and I think, she did have good union anteriorly there. Obviously, there's below the dominoes. And then no interbody really around that, 1 and 2 level. So looking posteriorly on her CTs, she did not have much bony union there.
And then what's that speckle thing that we see on the top end? We have about 5 minutes left.
She's got a spinal cord stimulator, which we also did address and take that out during her
so it worked really
most
well.
recent operation. Yes.
Yeah.
So.
Okay, that's a pending paper, the uselessness of dorsal column stimulators in the presence of somatic spine disease.
Yeah, maybe peace of mind there, but yeah, she, that was not functional.
All right, we have 5 minutes, so we got to kind of move on.
Underwent revision PSIF T4 to L2, interdiscal osteotomy, which we've mentioned before here. I'm just kind of going through the steps there. So, a nice laminectomy and fascitectomy, some pedicle to pedicle decompression that we performed, and then reached anteriorly to get 2 cages bilaterally. And the sequence that we see there, we did place hooks proximally into the transverse processes of T4 to give kind of a transition to the superior portion of our construct.
The soft landing, as Dr. Kang points it out. Okay.
So just bringing up a few articles, we did bring up a lot of this. CT is probably going to be our best way to diagnose a pseudoarthrosis if there is going to be one. It's difficult to determine a time frame for diagnosing a pseudoarthrosis. Can, as we've mentioned before, present years after the fact, up to a decade in some papers. And a lot of times in these papers, they'll just mention that the patient had a long-term follow-up within identification of a pseudoarthrosis. Looking at that paper, they did give a fusion rate for the osteobiologics. And I think in our case, we went ahead and just used a local autograft in addition to some cancellous chips. And then moving on to more studies here, it's difficult to say what the persistent pseudoarthrosis rate is. And again, it depends on how you're measuring that, if you're using an X-ray to identify or a CT. And then pseudoarthrosis really being identified at time of surgery. So that's important to identify if you're taking back for any kind of revision. And then orthopedic side notes were very aggressive with non-union, but the spine is just different, right? So how do you get bone to grow where it never has grown? And so, really a masculate technique, things like that are difficult to apply in the spine setting, especially posterolateral.
Tell us what a masculate technique is.
Yeah, so stage 1 and stage 2. Stage 1 is usually a cement spacer for a segmental bone defect. It creates a pseudomembrane around weeks 4 to 6. You have a really high level a BMP, where you'd like to go in for the second stage and do some auto and allografting at that time point to fill in the bone defect.
And tell us about nutritional management of people with non-unions.
Traditional management?
Yep, the nutritional.
Nutritional, yes. So vitamin D being the most common reason. So it's really important to get a vitamin D level. You always want to look at thyroid issues. You always want to look at really if they, do they have an iron deficiency? Do they have hemoglobin
So
abnormalities?
measuring vitamin D levels, making sure they don't have metabolic or hormonal problems.
BMPs, CBC, doing regular things.
And an albumin level, do you know an albumin threshold?
Right, so I think 3.5 or so.
Yeah,
anything
ideal
less
is
than that.
3.5 milligrams per deciliter.
Yeah, so you'd like to have a good protein.
Yeah. We actually put our patients onto hospital-supplied protein shakes beforehand.
Yep.
So
Yeah,
that's what all these crates are in the workroom.
It's a good move. It's a good move. PJK and failure. I know over our weekend talks, some people were arguing PJK being 5 degrees and then PJF being greater than 10 degrees. There's some intra-observer reliability issues in measuring 5 or 10 degrees. So I think generally 10 degrees is a good measurement. There's a nice pictorial here of the different transitional methods that we can use to help prevent PJK or F, but really there's no great evidence saying, hey, that this definitely works or this doesn't work. So I think the idea is very good, whether that's going to be cement augmentation, going with hooks to the TPs, or do some sublaminar wiring, tethering, or even some suture tape techniques. But again, there's...
And do you have a final outcome on the patient of Dr. O's?
So yes.
We have to kind of come to a close here. Sorry to rush you there.
Yes, so the final, it was just this one slide here.
You don't have a post-op CT? Or a
I did not bring up the post-op CT, no, apologize.
How's the
about
patient
that. She's done very well. She left post-op day 2.
You had an anterolisthesis. Go back to that slide, one of this. This anterolisthesis, did you get that reduced, Rod?
Yeah.
What'd you do?
We just reduced it intraoperatively. So there's a nice post-op CT that shows it.
Must come to a close. Wonderful. Any final comments from our faculty? Okay, otherwise, Dr. Marx, come on up. Thank you for being here. Thank you, James. Thank you for all of our fellows. So Dr. Marx is a Ph.D. in ceramic engineering. He is here on behalf of Therapeutics. He is Chief Operating Officer of this company and president, and responsible for clinical research. And he's done his ceramic engineering training and degree award at the University of Missouri in 1995. So he's been around for a while. I'm not calling you old. And he has been interested in regenerative medicine biomaterials. We intentionally chose these very recent cases to show you the clinical problems that we deal with. You had a little off script, more or less discussion about what we currently believe and not.
Yep.
And again, we are all looking for the panacea of bone healing. So tell us about P-15.
I may disappoint you if you're looking for a panacea, but so appreciate Dr. Chapman and then Seattle Science Foundation for this opportunity. I'm very excited. Again, this is non-CME, but I am the President and Chief Operating Officer of Therapeutics, so please keep that in mind with regard to bias. I always do try to, whenever I do talk, do as if I were speaking at a CME. So I'm going to start here, and as was discussed throughout this morning's case presentations, there is no clear right answer for bone grafting. And I think, unfortunately, there's an awful lot of sort of confusion and misinformation, and every patient is different, so their metabolic needs are different, and we don't really have a great algorithm for choosing who gets what and when and why. And I'm not going to really be able to give you all of that today, but hopefully I'll give you some information to help you make decisions. So this is a paper that was published by ISAS a couple of years ago. I think they did a really nice job of categorizing all the bone graft materials that were available. They put them into these categories here, as you can read on the column on the left. They went a little further than that. This paper was basically written in the form of chapters. And then there's a chapter on each one of those categories wherein they talk about sort of the technology and the history, a little bit about the mechanism of action, but the most important thing is they end each chapter with what is the human clinical evidence on which to base a clinical use decision on each one of these. So I'm going to be talking about our product, iFactor, which is a drug-device combination product. So the bottom category, there are currently only 3 FDA-approved drug-device combination products and only 2 approved in the spine. And those are Infuse, which was talked about quite a bit through the case presentations, and then iFactor. So I'm going to shift gears, and in that paper, they also talk about regulatory pathways, and I think this is poorly understood in the surgical community. We built this little pyramid here to describe, so at this point, there are over 400 bone graft materials that are commercially available in the United States, and they fall into one of these 3 categories. So on the bottom are HCTPs, or human cell and tissue products. So those are under Section 361 of the Code of Federal Regulations, which states that these must be minimally manipulated for homologous use, and they cannot rely on the metabolic activity of living cells for their primary function. So this includes non-structural allograft, and in spite of the description I just gave you, it also includes the cellular allografts. So those materials are being marketed as HCTPs. The regulatory requirement for HCTP products is really none. You want to sell one of these products, you send the FDA a letter, you tell them that you're going to follow their guidance documents for tissue procurement and processing, et cetera, and then you're on the market. Moving up to class 2, this is the biggest category. This includes this includes demineralized bone matrix materials with a carrier. Just pure DBM without a carrier is generally marketed as an HCTP, and the class 2 products also include synthetic bone grafts. So the requirement here is what's called a 510K. So in 1976, when the Food and Drug Act was enacted and FDA was created, there were tens of thousands of products already in the market, and they were basically grandfathered in. And they created a pathway whereby if you could demonstrate substantial equivalence to one of those pre-market devices, and the means of doing that are different depending on the product. For bone graft materials, the FDA's current expectations are a single animal study. It can be a drill defect in a long bone, and that is for an extremities label. And then if you want to have the word spine in the label, they're generally expecting a posterolateral fusion model done in a rabbit. So if you show in those animal studies, the bone formation and resorption are adequately similar to the predicate device, that gets you a clearance for marketing as an autograft extender in the posterolateral spine. Finally, on the top is the most rigorous category. So these are the class 3 drug device combination products, which the FDA requires a prospective randomized level 1 investigational device exemption clinical trial. And what you have to demonstrate to FDA to their satisfaction is safety and efficacy based on that study. So I described that the HCTPs, you send the FDA a letter. This is just to try to give you a little bit of an indication for our cervical IDE study. This on the table in front of us here is 2 copies of the 4th module of our PMA filing. So that was the clinical study. Yeah, you can see the list of what was involved in all the others, but this was over 9,000 pages for this module alone as compared to a letter, or in the case of a 510K, those can be hundreds of pages in total, including the animal study results. So let me now introduce the technology, and this is sort of a busy slide. There's a lot going on here. So starting on the upper left, so cancellous bone and cortical bone are also a remarkable biocomposite material of approximately 50% mineral, calcium phosphate, hydroxyapatite, and about 50% predominantly type 1 collagen. There are also trace amounts of non-collagenous proteins in there, GAGs, BMP, et cetera, but it's 95 to 98% collagen type 1. So that collagen is in the form of fibers, and those fibers are comprised of fibrils. If you keep working your way all the way down, the type 1 collagen molecule itself is a triple helix. There are 2 alpha-1 chains and an alpha-2 chain. The alpha-1 chains contain a 15 amino acid sequence that we call P-15. And when the local cells attach to all of our connective tissues to collagen, it is at that segment. So when this sequence is manufactured and then put onto the surface of virtually anything, cells will stick to it like crazy, and they will be turned on to perform their genetically programmed function. And the image on the bottom right is sort of showing that peptide being bound to the calcium phosphate carrier as it is in our product, iFactor. So this eye chart here, I apologize for those of you online, it's probably really, really hard to see, but This is a map that was published a number of years ago. I think when most of us learn about collagen, we really think of it as being sort of the rebar of our tissues that provides the elastic properties and tensile and shear strength, et cetera. But it also, as we're learning more and more, with most of this research being fairly recent, collagen has an enormous influence on driving cellular activity, both in de novo tissue formation as well as in injury response. So this is effectively a map of the type 1 collagen molecule, left to right, top to bottom. And every one of those notations is a segment of the molecule that has been found to have an important biochemical signaling function. The little breakout section in the purple box over the left, that's what's called the cell interaction domain. And the remainder of this map is the matrix interaction domain. And within that cell interaction domain is that P-15 sequence. And the P-15 sequence has been shown to have orders of magnitude more cellular activity than any of the other identified peptides to this point. So very interesting to note, believe it or not, there have been some fossil specimens of dinosaurs, 65 to 68 million years old, that have been found with some intact segments of type 1 collagen just due to the remarkable way in which they were preserved. And in at least 3 species, they have been able to sequence this cell interaction domain and found it is 100% conserved, the same as in modern humans. So that just sort of speaks to how incredibly important this must be in terms of evolution in ways that we still don't even understand yet, and we'll just learn more about over time. So we like to describe the mechanism of action, which is different than what most of us have learned. Most of us learn about bone biology requiring an osteoconductive, osteoinductive, and osteogenic matrix, and I think that's generally true. However, the mechanism of action of P-15 is different, and we like to describe it as it will attract, attach, and activate bone-forming cells upon implantation. So this brief animation here, this is a time-lapse sequence. So these are mouse MSCs. The section of this is coated with P-15 and it was wiped clean. And then here over the course of just under an hour, you can see all of those cells migrating across. It's an oversimplification, but I like describing those pseudopodia as effectively grabbing onto those P-15 anchorage sites. So there's been an enormous amount of preclinical work looking to try to understand this attract, attach, activate mechanism of action. And for those of you who are interested, I've got lots and lots of references throughout here. So one of the nice things about this technology is you can do very straightforward in vitro testing with the substrate with and without the peptide. And you can show very clearly enormous increases in the number of cells that are bound to that surface because of the P-15, as well as the cross-sectional surface area that's covered. And on the right, on the left, so these are pre-osteoblasts. The one on the left was cultured on just the calcium phosphate surface alone. You can see some cytoskeletal structural spreading, some pseudopodia. And then on the right, the same cells cultured on the same substrate, but in this case coated with P-15. And you can see enormous difference in the number of pseudopodia expressed, as well as the flattening and spreading of these cells. Those can also then be measured, and I'll talk about in a second, in terms of the cytokine production by those cells. But let's talk a little bit more about the core of the biochemistry here. All of the cells that we're interested in for bone formation, whether they be undifferentiated mesenchymal cells, pre-osteoblasts at any of their stages of differentiation, all the way down to fully differentiated osteoblasts, all of these cells have surface receptors that are actively looking for this P-15 sequence. And so these are alpha-2 beta-1 surface integrins. And you can just think of these as being like locks on the surface of the cell. You simply plug some of these P-15 keys into those surface receptor locks, and that turns on the genetically programmed function of these cells. Those will then aggregate. They'll send a signal across the cell membrane, that sort of gray surface there. Within the cell, you get aggregation of focal activase kinase, and then that turns on multiple downstream biochemical events, all of which lead to the transcription and production of proteins, peptides, turning on bone formation, as well as attracting additional cells into the site. And most of those things can be measured directly and simply in vitro, and you can measure meaningful large increases in the production of alkaline phosphatase, BMP2, bone sialoprotein, really all of the markers for bone production are readily measured and are increased meaningfully in the presence of P-15. So in these next couple of slides, I'm just going to tease some new data really quickly. So this is new data that has not yet been published. It's going to be presented in full for the first time at the upcoming NASS meeting. And then here at Seattle Science Foundation the following week by Boyle Cheng from Allegheny Health Network. So this is just a picture of Dr. Cheng and his team who has done this work with us. Here's just a different way of looking at bone healing. So normally when we talk about bone healing, we're normally looking over on sort of the right side of this graft. You know, when you're doing in vitro testing and in vivo testing, you're really looking at the later time stages in the terms of days or more likely weeks and months. But we thought it would be really interesting and important to try to understand what is happening with the immune system at time 0? And does this P-15 sequence have an influence on that immune system? Because that's really what drives everything. So all healing starts with inflammation. And this is, again, a gross oversimplification, but there's largely good inflammation that leads to healing, and then there's bad inflammation that leads to clinical challenges, et cetera. So we created a program with some in vitro experiments that I'll talk about briefly, as well as some in vivo work that I will defer and let Dr. Cheng talk about. But we were able to measure marked changes in all of the positive inflammatory markers and decreases in the negative inflammatory markers. And these markers are generally pretty well understood, TNF alpha, interleukin 1, all of these, et cetera. So again, but in contrast, and this was part of the discussion this morning, while it looks like the P-15 sequence turns off bad inflammation and turns on positive healing inflammation, BMP2 does the exact opposite. And as was discussed, there certainly are some rare, luckily, instances in which that can lead to a clinical consequence, but this is pretty well understood and established in the literature. So let me now talk about, all that's preclinical stuff, which is interesting, but at the end of the day, you guys aren't operating on, athymic rats, et cetera. So what about the clinical experience? So iFactor has been commercially available since 2008 outside of the US. I'm gonna be very careful here in talking about on-label uses only, but I'm gonna describe the fact that it is different in different jurisdictions. So in 2008, iFactor was introduced to the market in Europe. The CE mark is for the entire skeletal system, and that wealth of clinical experiences throughout the spine and elsewhere in the skeleton. And there are multiple prospective human clinical studies. I'm not gonna discuss those, but certainly in a medical affairs context that can be done. In the United States, it's approved for single-level cervical fusion. I'm going to show you the indication statement in a minute, but that was based on an FDA IDE clinical trial in single-level cervical fusion. At this point, iFactor is not only the fastest-growing bone graft worldwide in terms of its clinical use, but we're well north of 100,000 procedures performed. So here's the indication statement: single-level cervical fusion inside an allograft ring. You can ask a lot of questions about that. Why an allograft ring? Well, this study was initiated before the first PEEK cages were approved, so this is going back quite some time. Clinical practice changes over time, and it's sort of hard when you're doing studies that take 8+ years to be current. So we are looking to address that. So here are the designs of 2 IDE studies. The one on the left is our cervical study that's completed. This is the basis of our current FDA approval. So single-level cervical fusion in 319 patients with an allograft ring. The patients were randomized to either receive iFactor in that allograft ring or autograft. There were 4 primary outcomes in this study, which I will show in a second, as well as a composite combining those. And all of these patients have now been followed out to 72 months. On the right is an IDE study that's currently underway. So this is for the next generation version of the product. So we just completed enrollment of this study in February. So this is a single-level TLIF study. Patients were randomized. They either received our experimental P-15L material inside of and surrounding a static PEEK cage, or the patients were randomized to the control, received autograft. These patients are all being followed to 2 years for their primary outcome, but they will all be followed for 72 months for safety purposes. So this is a brief animation. So this is CT fly-throughs. So this is a single patient who received I-factor and a single level ACDF. You can see immediate post-op on the left, this just sort of amorphous block. That's just the radio density of the unresorbed calcium phosphate material. In the middle at 3 months, and this is going to come back around in a second. By 3 months, this has already formed mature lamellar trabecular bone, which I think is fairly remarkable. And then at 6 months on the right, it's formed a new cortex. So what we see in the general use with I-factor, particularly in the approved indication of ACDF, is very, very rapid bone formation and fusion, followed by very, very rapid resorption of the calcium phosphate material as part of remodeling. So these are the results of our IDE clinical trial. It was a non-inferiority trial design, and all 4 of the primary outcomes here, so radiographic fusion, neurological disability, neurological success, and safety success, while I-factor was numerically better than autograft for all 4 at both 1 and 2 years, they were not statistically different, as would be expected in the non-inferiority trial design. However, in the red box over on the right, this is the overall success metric. So this is individual patients who were successful for all 4 of the primaries, and I-factor was in fact statistically superior to autograft at both 1 and at 2 years. So a little bit of, a lot of people say single level cervical fusion is straightforward. Fusion rates are very, very high, and that is absolutely true. But if you look in the literature, the very best sort of controlled cohorts are the fusion arms of the cervical disc arthroplasty studies. And this slide shows the results from those fusion arms of all of those studies. And the 97% fusion seen in our study compares very, very favorably to all of those. So just to sort of summarize here, so this powerful attract, attach, activate mechanism of action leverages native biology in a way to achieve rapid fusion and remodeling, really without the potential for side effects. There's no action at a distance, there's no ectopic bone formation, there's no adverse inflammatory response, et cetera. Showed statistical superiority to autograft in ACDF. Again, not the most challenging application that we're aware of, but I think the results speak for themselves. We have an FDA IDE study ongoing in TLIF. We're currently expecting approval on that in sometime in late 2024. I didn't discuss here because of lack of time, but a very, very sophisticated medical economic analysis was done based on the entire database from our cervical study, and it showed meaningful cost benefit to both society and payers for I-factor as compared to free autograft. So the safety profile in our cervical study was exactly the same as autograft. There were no differences in adverse events. So extraordinarily powerful and yet safe. And this gives you an option to practice evidence-based medicine and value-based care. And with that, I'm hoping for a good discussion, particularly with the setup from this morning.
Thank you, Dr. Marx. I love those animations. I think I speak for everybody. Those are very cool, and I think the biochemistry and cellular physiology was really well illustrated, and the complexity of bone healing was also well illustrated. Maybe you can go back to that beautiful timeline slide that had the various immunologic and cellular factors juxtaposed. And if I may start off the questioning, yeah, fantastic picture. I've not seen that, actually. I need to look for that. So as we keep this in mind, what is the ideal, the best realistically usable animal model? Obviously, primates are off limits for a variety of reasons. But what, in the big picture gestalt, is the best animal model to prove the veracity of a bone graft substitute?
There's unfortunately not a great answer for that. One of the things that was discussed this morning is that there are so many risk factors in humans with regard to the metabolic state, the biomechanics, et cetera. The translatability of various animal models is enormously varied. I think the very best we can do are large mammals. Sheep, I think, are probably among the best that we have, but they're not great analogs because the biomechanics are different, the spine is horizontal, et cetera. But in terms of the rate of metabolism, it's probably as similar as we can get without doing primates.
So yeah, I think that's a very insightful answer. Dr. Wang, when asked that question, said sheep models don't count because sheep heal anything. You can put a piece of wood in there. I think he said the verbatim, and it'll probably heal. So, but this is one of the problems, isn't it? We don't have a great model. We use rats and we use rabbits and try to infer from that. In the human test literature, what would be the most objective way to test for fusion maturation in your perspective?
Yeah, I think the literature is pretty clear on that. Thin cut CT is...
That's a modality, but what anatomic site would be the best?
Oh, boy. I think different skeletal location. I think they behave differently. You know, I think particularly, so those of you who trained in orthopedics, you know, you learn about sort of fracture healing and this callus formation, sort of endochondral bone formation. And that's what typically happens with the use of BMP or a DBM. What we have shown with I-factor through various animal models, and I certainly think that CTs show it, is we're seeing intramembranous bone formation, where you're going directly to bone and skipping the cartilage phase. I think that's a function generally in what materials are being used, as well as the skeletal location. So I believe that you know, inner body spine is perhaps the most translatable to other parts of the skeleton, but that's not, there's nothing really sort of supporting that. That's just kind of my bias.
And before I ask our visiting faculty to also weigh in, especially to my question of what they would like to see as a clinician where bone formation takes place, I have my own opinions. Let me ask you a physiologic question. I was just visiting professor at UPenn, and obviously the spirit of Carl Brighton was pervading their current lab. They have 150 people working in their lab, amazing output there, and a lot of it focuses on bone healing, very different angles from yours. What is the actual influence of electrical stimulation on bone healing in a percentage thing, and why does that work in this era with your insights into molecular biology?
Yeah, so I'm not a molecular biologist, you know, I just play one on TV, but my best understanding is, so if you just go back to normal physiology, so Wolff's law tells us that bone will remodel in response to stress. And our best understanding of that to date is that bone is actually piezoelectric. So when you put a compressive force onto bone, it will actually create a local surface charge, so a positive ionic charge. And regardless of the type of electrical stimulation that you're applying, or in some instances, some folks are putting in resorbable, so ions that have a positive charge, that seems to suggest that same situation to the local cells. So, you know, electrical stimulation creates a positive charge, or a soluble, small, highly charged positive ion seems to do the same. How long that lasts, I don't think is terribly well understood.
And the pathway, as I understand from Ted Gross, who's at UW and worked in our labs there, is through calcium channel mediation. So the calcium channel is the intelligent pathway of networking of bone cells. So let me ask our colleagues here. So Dr. Kang, I'll bring your microphone. What would you like to see as a clinician, outside of a happy patient radiographically, to be assured that a substance X, let's just call it X and not P or B or whatever, that this actually works? What would convince you as a clinician this substance has a meaningful impact on bone healing?
Yeah, I mean, it's hard to get radiographic images or CT on a monthly basis. So I think obviously number one, earlier bone healing. I think seeing those radiographic indicators that there's bridging bone either through the disc space or around the cage would be ideal. But yeah, it's hard to know when that happens. And ultimately, when we start talking about returning them to full activities, and for some of our really highly active patients who police officers, military, trying to get them back sooner. I think for me, that'd be convincing if I had early radiographic evidence, not just even CT, that you can see it in front or behind, but I agree the posterior lateral stuff and posterior fusions through the facets, I mean, that's just so hard to tell. And I think for the reasons you're saying in the compressive area, you can probably study that the best, but that would probably be what I would look for.
You're reading my mind. I was gonna say posterolateral area in a lumbar spine with an open procedure. That's the most unforgiving area. That's the one where if I see bone, and on some of those cases, like my failure case, We had a beautiful posterolateral fusion mass down to L5S1. There was nothing between that famous junction. How can we or what do you teach your residents and your program about the volume of bone graft? So Jeff Wong made the very important statement of, I like a lot of bone graft. We don't put enough bone graft, and it's not some magic paste that'll somehow form a miracle cloud of bone unless you're head injured or have some miracle sprinkle in there. So what do you tell your residents or fellows to put into the gutter to get a proper fusion?
Yeah, so I've seen it done various ways where, yeah, people are stuffing in a ton of bone graft, and sometimes you go back there and it's incompletely incorporated. I mean, I don't know if the blood vessels can grow all the way down into that area, but I've also some people with very minimal bone graft. They just put a little strip of DBM and they call it a day. But I don't know what that ideal amount is. I think you have enough to fill that dead space and also the muscle to be able to actually kind of cover it. I try to fill the space enough to where it's contacting the sides of the muscle and in and around the screws.
Yeah, because that's near and dear to my heart. You need to have a proper decortication of properly exposed posterolateral bone elements to actually get bone healing. And what I frequently see is just barely the wisp of bone, and there's barely a touch of the Midas or whatever tool you use to decorticate, and then there's a lot of muscle and stuff in there, and you somehow hope that this congeals. John Blair, you're an older guy like me. I was trained with people who did not use electrocautery dissection for wide open posterolateral discussions. The exposures I was trained with were usually pretty kind of cursory with a cob, and there was a lot of bleeding and it was stuffed off, and then an hour later or two, a lot of autograft is stuffed in. But you know what? It healed. It's formed a lot of bone. Are we killing our bone graft nitises with too much electrocautery?
Yeah, that's a hard question to answer.
Can you speak close to the microphone, please?
Sure, that's a hard question to answer. Hard topic to really, determine and study. I would say that using judicious amount of electrocautery is perfectly appropriate. I think that doing a good decortication is certainly critical to getting a good fusion. Paul Anderson, he really likes to decorticate the facet joints and really stuff as much bone into the facet joints as possible to get a good fusion. Jim Ogilvy had a technique where he would actually put structural corticocancellous iliac crest graft underneath the transverse processes. So he would actually put graft there and have a bridge underneath the transverse processes so that the muscle wouldn't push away the graft from the TPs. And that seemed to work very well for him.
How often do you still use autograft? At all?
Nowadays, hardly ever.
Why? It's right there when we do a lumbopelvic fixation.
It is right there. I've had generally pretty decent successes now with just using allograft, local bone graft, and doing an interbody fusion for the majority of cases, and then reserve the iliac crest for the failures for the pseudoarthroses.
Dr. Martin, bone marrow aspirate. You're again old enough like me where this was the rage 20 years ago and it seemingly has vanished. What happened? Did you use it? What do you do now?
No, I don't use any bone marrow aspirate. There's one of the products that I'm using now needs to be hydrated. Sometimes if I can get some blood out of the pedicle, I'll mix that in. It seems to me that it would be better than just saline. But no, I don't routinely use it. I think for a posterolateral fusion, it's all about the decortication. I'm really aggressive biting off the lateral portion of the facet joint and exposing the TP, decorticating the TP, decorticating the facet joints aggressively. And I think more bone is better. I pack in as much as I can. I think that's the key. I haven't noticed so much of a problem with the cautery. I do use the Aquamantis now for the fusions because I think it does a little bit less tissue damage. I also think it's quicker and easier to control bleeding with that than it is with the monopolar cautery. But I think it's basic orthopedic carpentry. You have to do a good decortication and stuff as much product, whether it's local. I use mostly local bone and some extender for the majority of my cases. Reserve iliac crest for redos, and I will use it for young trauma patients when I'm trying to do a short segment fusion to make sure that they have a high chance of healing.
Fotis, tell us about your clinical experience a little bit. Thanks for coming, by the way, over from Denver. It's very cool.
Yeah,
It's
no,
nice to
I
see
think
you.
this has all been a great discussion. I will say, I think it's very patient specific. Like we've all seen this, right? We go back on someone and there's like nothing. Then we go back on someone, there's like, holy cow, there's all of these biologics, autograft, allograft. The more recalcitrant the bone former, the more love and care we have to put into the decortication, the thought process of what we're going to be using, et cetera, whether if it's a redo pseudo, BMP may be the right thing. If it's one of those in between 50-year-old, I don't know what, but it's a longer construct, not only do we have to contemplate how many screws we're placing, as we talked about this, the more screws we place, right, the less screw stress we place, but the more stress we place on the rod, hence the quad rod constructs, tri-rod constructs, et cetera. We're always creating another problem somewhere down the road, so we have to think about this. But those in between, that's where I love, and yes, granted, I'm a consultant for therapeutics, but that's where in these in-between patients, I love the concept of I factor, because this is where early on in my practice, I wouldn't use anything just besides autograft and allograft, and it's wonderful to have this evidence, and the science is impressive.
And how do you dose that? How many milligrams per level for a thoracolumbar spine would you use?
Yeah, that's a great question. We can talk offline. I'll tell you about
let's
it.
do that.
Yeah.
Dr. Covey, you're in a large healthcare system, cell-based bone grafts. Osteobiologics is such a huge business. Can you pass the microphone to Dr. Covey? In a large healthcare system, money matters a lot and everything gets surveilled. Cell-based products were the rage for 10 years now. There's been a heavy industry push towards having cell-based products. What was, without mentioning your healthcare system, it's a very large one, what was the policy? There have been any restrictions on the use of cell-based bone graft substitutes?
No, it's typically been surgeon preference. But most of us, I think, have gone away from cell-based products.
Why?
At this point?
So you have our shop is closed. We don't literally do cell-based products anymore because the evidence was actually unfavorable.
Well, there have been some studies. There was a good presentation here a couple of years ago that the evidence of cell-based products wasn't very good. And there was actually, and it's a lot more expensive. The problem, I guess, is always, about meticulousness is it's very easy to be meticulous on a single level fusion. It's these, T10 to ilium where I think is a bit the problem, because that's where, by the time the rod is in, and then you do your decortication, that's always the challenge. And those are, of course, the cases where the risk of a non-union is ultimately much, much greater. That's where you think, oh, yeah, let's do quick decortication. And I'd like to think that relatively meticulous, but I know I'm less meticulous than if I have a single level, like an L4-5 TLIF.
Dr. Marx, thank you. That's a great comment on several levels. Dr. Marx, so your company frequently competes against BMP, and it's becoming off patent now, so there'll be more competitors in that field and pricing will be different. What would you say, however, if you were asked to compete against or compare against cell-based products? Is this a sensible option? Is this better than the usual autograft and allograft mix that most of us use?
I think the evidence at this point points that the cellular allografts are really extraordinarily expensive DBMs. There really has not been anything demonstrated that they provide a clinical benefit. I think that the biochemistry is really not well understood. So mesenchymal stem cells are immunologically privileged, but once they differentiate down the path towards osteoblasts, they express the surface antigens of the donor and they're going to turn on an adverse response. So we don't really know what that means. There have been some studies done where they radiolabeled the cells and looked at survival rates, and they're extraordinarily low. So I think if they are providing a benefit, it's as a sort of short-term cytokine production pump locally. I think you can get an $11 GMCD needle and put in 100 or 1,000 times as many of the patient's own cells, rather than paying $3,500 a cc for those products. That's my...
Appreciate the succinct and clear answer. Final question from my end. Obviously, we use biomaterials like cages and screws. What is your preferred cage? I know you're not a clinician, but you've looked at thousands of x-rays, you've looked at cellularity, you've looked at cell attachment and that early vulnerable hour phase.
Yeah.
The initial mesenchymal fibroblasts, the undifferentiated fibroblasts that attach or not attach to surface areas of cages. So between titanium, carbon, whatever, composites, allograft and plastic, meaning PEEK, the insurmountable wall of PEEK. What is your favorite thing? What would your preferred substance be that we as clinicians use?
If you're looking at purely from the perspective of cell interactions, titanium, and particularly, and I was involved in the early development of microtexture acid etched titanium. So the Titan spine, we developed that when I was at Orthovita. Cells respond very, very positively to that, and you can get direct bone apposition. You typically don't see that with PEEK. There are PEEKs that are embedded with hydroxyapatite or surface coated with hydroxyapatite. I'm worried about those long-term in terms of interfaces and spalling off with long-term mechanical cycling. I think we're going to have a lot more to say about how bone reacts with PEEK when Dr. Cheng presents our in vivo data, because I think there's a lot of it that we don't understand. But as of today, right now, PEEK will biointegrate, but that comes at the cost of radiographic assessment.
I just have one question on, when we go back, like when we rivet, whether it's usually it's BMP found, is it seems to be much weaker. It's got a different architecture than normal. I don't know, Jens or Bob, but it's bone, but it doesn't have the same. And I did my medical school at UCLA, where the orthopedics department there is big, and they talk about how important it is. Bone grows through these phases. And osteoblasts, osteoclasts, I mean, there's lots of, it's like if you build a structure with a good foundation, and I don't know if you guys have any of this, it would be interesting to me is to look at the histology of, let's say, like BMP versus autograft versus allograft versus regular, bone, and what that looks like, because I feel like we sometimes cut corners on these things. But I don't know if you guys have any data on that.
Yeah, so in addition to that, those CT fly-throughs I showed, we commissioned some work using cone beam CTs, where they then developed a 3D finite element model, and modeled not only the trabecular thickness, but also the directionality of the trabeculae, and were able to sort of translate that into a mechanical model that showed very rapid restoration of normal physiologic structure of that lamellar trabecular bone, which should translate into a very normal biomechanics. I think most of us are familiar with, eggshells forming with BMP, particularly in posterolateral, et cetera. So the mechanisms of action and the pathways and steps, as you described, I think are very, very different depending on which material that's used. With iFactor, we generally see direct intramembranous bone formation. You go straight to bone very, very rapidly, and then that remodels. With other materials, depending on what they are, sometimes there's something that's sort of in the way for a while. It takes a while for it to get out of there. But yeah, getting to fusion as rapidly as possible, and having that be as physiologically competent as possible, I think is an enormous part of achieving your clinical goals.
Yeah, great talk, great talk. I don't know that I have a lot to add, but the fellows most of the fellows have had to go position our first round of patients in the operating room, so many of them are gone. But I do like to talk about the principles of spine surgery, and in terms of fusion, one of those is the biology of bone fusion, and the second is maybe the biomechanics of bone fusion. And for the compressive forces in the disc space favor fusion as opposed to the posterior elements. The proximity of the bony surfaces in the facet joints posteriorly favors fusion as opposed to trying to span the transverse processes, as most of us were taught years ago. And then the volume of bone graft, the biological efficacy of the bone graft and bone material, all are incredibly important, as well as the stabilization with pedicle screws and instrumentation, or I guess with whatever instrumentation we use, we need to make sure that it's mechanically sound.
With that, we'll come to a close. Thank you, Dr. Marx.
Thank you.
Thank you all for your contribution.